Diagnosis of DKA depends on the symptoms and signs and recognition of those symptoms and signs in diabetic patients. In general, symptoms of diabetic ketoacidosis reflect symptoms of hyperglycemia, acidosis, and dehydration. Glucose levels are generally over 300 milligrams per deciliter, while acidosis are apparent with a pH of less than 7.3 and presence of ketosis as measured by the nitroproside reaction or specifically by b-hydroxybutyrate level. These are the signs and symptoms of diabetic ketoacidosis and HHS. In general, diabetic ketoacidosis occurs over 24 hours. These are the signs and symptoms of DKA and HHS. In general, diabetic ketoacidosis occurs over relatively short time, about 24 hours. However, HHS develops over days. And the symptoms are generally of polyuria, polydipsia, anorexia, nausea, fatigue, weight loss, abdominal pain, which usually correlates with the severity of acidosis, and leg cramps. The other symptoms and signs are related to dehydration, hypotension, tachycardia is very prominent, hyperventilation, generally described as cosmal respiration, which is deep, rapid breathing, and if you're close to the patient, you may be able to smell acetone, a fruity smell. Gastric stasis and hypothermia are apparent, and impaired consciousness only appears in severe DKA or HHS. Generally, it correlates with osmolality, and it correlates with levels that are more than 320. And it is more in HHS than in DKA. So we should always suspect a DKA and HHS in a patient that is presenting with coma and shock, dehydration, and respiratory distress. And diabetic patients are usually candidate for DKA if they have nausea, vomiting, abdominal pain, depression, short of breath, or unexplained blood sugar more than 250 milligrams per deciliter. So these situations should raise alarm that the patient's probably is having or impending DKA. One should be familiar with anion gap, as these are the parameters that one would follow in the management and diagnosis of diabetic ketoacidosis. As you know, there are some anions that we do not measure in the formula for anion gap, and these include albumin, lactate, phosphate, and sulfate. So normally, there is an anion gap that is 8 to 12. However, there are also other high anion gap acidosis that can be confused with diabetic ketoacidosis. These are lactic acidosis, rhabdomyolysis, uremia, and acidosis due to ingested acids and their metabolites such as salicylate, ethylene glycol, methanol, and others. In general, most of those high anion gap acidosis, the glucose is normal or certainly not very high. The other formulas that one should be aware of, again, it's important for diagnosis and follow-up, are the following formulas. As I mentioned earlier, the anion gap is measured by subtracting chloride and bicarbonate from sodium, and this is about 8 to 12 millimole. The correction for serum sodium, since with hyperglycemia, the sodium is depressed, and the correction factor is about 2 milliequivalent for each 100 milligram of hyperglycemia. The other formula that one should be aware of is effective serum osmolality. Effective serum osmolality, these are the osmoles that are responsible for the symptoms and that correlate with the severity of hyperglycemia. These are measured by multiplying sodium and potassium and glucose in millimole per liter. Since urea is usually diffuses across the membrane, we do not count it in the effective serum osmolality. The effective plasma osmolality is usually measured by measured plasma osmolality minus urea. This table essentially lists the differences between diabetic ketoacidosis and HHS. As you can see, hyperglycemia is prominent across the two states. However, it's much more prominent in HHS, with blood sugar usually more than 600 milligrams per deciliter. In DKA, pH is usually depressed, there is acidosis, while in HHS, the pH is usually more than 7.3. Ketones in general are positive and markedly so in diabetic ketoacidosis, and either small or absent in HHS. Serum osmolality again is usually variable in DKA, while it is usually higher in DKA, higher in HHS. And altered sensorium usually occurs in severe DKA, however, it is common to see it in HHS. There are 3 ketone bodies that are identified in diabetic ketoacidosis. These are b-hydroxybutyrate, acetone, and acetoacetate. In fact, only acetone is ketones, while b-hydroxybutyrate and acetoacetate are the acids. Acetoacetic acid is the only true keto acid. And the nitroprusside test that we use commonly to diagnose diabetic ketoacidosis measures mainly acetoacetic acid. However, it is beta-hydroxybutyrate that accumulates in excess. And in certain conditions, the nitroprusside test can be negative due to accumulation of beta-hydroxybutyrate, especially in conditions of tissue hypoxia and hypoperfusion. There are certain drugs that cause false positive nitroprusside tests, such as drug containing sulfide groups such as captopril. So as I mentioned earlier, acetone is not an acid, it is a ketone, and therefore it does not contribute to anion gap or the acidosis in DKA. It is a true ketone, and it forms as the patient recovers from diabetic ketoacidosis, and therefore you may find as the treatment goes on that acetone increases in the blood and the urine, but that doesn't mean that the patient's getting worse. However, measurements for hydroxybutyrate, if available, will show you that the level of hydroxybutyrate decreases with the treatment of diabetic ketoacidosis. There are a few points I'd like to mention about urinary ketones. A negative trace or small quantity of urinary ketones virtually exclude diabetic ketoacidosis. There is exception, however, uremia or high intake of alcohol may actually give you a small ketone reaction in the urine. A moderate or large ketone bodies raises the possibility of DKA but does not diagnose it. DKA and HHS usually occurs for a reason, and one should always look for that reason. 80% of episodes will have an identifying precipitated factor. The most common one is infection, accounts for about 37%. The treatment error, other pathologies such as myocardial infarction, drugs, alcohol, endocrine and miscellaneous pathologies can precipitate DKA. These are usually not common, such as Cushing's, acromegaly, or pheochromocytoma. Pancreatitis and other abdominal emergencies and stresses, such as gastroenteritis, can be a precipitating factor of DKA. And sometimes we do not see a precipitating factor for such condition. Here are the estimated deficits in both DKA and HHS. A patient will lose between 6 and 9 liters of water. As I mentioned earlier, 300 to 600 milliequivalent millimole of potassium, and about 7 to 10 millimole of sodium per kilogram body weight. And the others are also lost, although their significance is not as that of potassium and sodium. Occasionally, amylase and lipase are measured when the patient presents with abdominal pain, and suspicion of acute pancreatitis is raised. However, this only occurs in less than 10%, and usually due to hyperglycemia or alcohol. These are the precipitating factor for acute pancreatitis. However, elevation of amylase and lipase can be seen in 17 to 20% of patients, and usually this is due to salivary amylase. However, increase in the level of lipase is unknown source. Patients with DKA will have leukocytosis irrespective whether they have infection or not. This is probably due to hypercortisolemia and high catecholamine levels. However, levels in excess of 25,000 and bands in excess of 10% should increase the suspicion of infection, even if it's not apparent. Normally, we do not measure lipids. However, if they are measured, it's not unusual to see triglyceride levels in the excess of 574 milligram per deciliter and cholesterol level around 212 milligram per deciliter. This is, of course, due to insulin deficiency and lipolysis. Some useful hints to estimate the deficits: when there is hypotension present, that usually suggests a 10% dehydration. Normal body temperature in DKA does not rule out infection, and one should look vigorously for infection. EKG should be done in patients who have diabetes more than 15 years or in elderly, as ischemia in diabetics may be silent. The differential diagnosis of diabetic ketoacidosis are alcoholic and fasting ketoacidosis. Generally, these are easily ruled out by the fact there is modest elevation in glucose, if any, and ketosis that are usually very low. And if you happen to have hemoglobin A1C, it usually is normal in such condition, indicating the patient is not diabetic to start with. Like everything in medicine, there are exceptions to the rules. However, these should be looked at exceptions, and these are extremely rare. And in my 20 years of experience, I hardly find these exceptions, maybe one in 10 years. So there sometimes occurs a euglycemic DKA. This usually occurs as a result of excellent hydration by the patient. The patient is well educated, drinks plenty of fluid, and take frequent and extra insulin doses, and so will come to the emergency with a normal blood sugar. However, he will be acidotic. In pregnancy, sometimes due to lower threshold of renal glucosuria, glucose is excreted in the urine, and the patient may have normal blood sugar. Also, the fetus consumes a lot of glucose, and so that will contribute to lowering of the glucose in DKA. Alkalemic DKA is another exception and usually occurs in the setting of metabolic alkalosis, such as severe vomiting, diuretic use, alkali ingestion, and rarely, very rarely, in Cushing syndrome. Non-ketonic DKA, again, as I mentioned earlier, when there is disproportionate elevation of b-hydroxybutyrate due to tissue hypoperfusion or hypoxia, there will be very little acetoacetate formed, and therefore you will not measure this in the nitroprusside reaction. And rarely bicarbonate may be normal in chronic respiratory acidosis.